So in the last class, we were just discussing the importance of sample collection. What are the errors that can occur during sample collection? How does it reflect on the values, especially oxygen and PCO2? What are the common abbreviations we get on the ABG slip? And what are the important things you should remember? We also remember the famous personalities, Henderson Hasselbalch. You gave us the equation. We discussed how will you identify a primary abnormality, how will you identify a mixed acid base, and we went on to discuss metabolic acidosis, the discussion on anion gap, and what is anion gap, and we discussed various causes of anion gap metabolic acidosis with illustration of cases. Okay, so we stopped at that level that time. So now we will see another case scenario. Kishan, it's all right. You can see the slide. I'm audible.
Yes, ma'am, it's clear.
Okay. This is a story of a 3-year-old child who presented with history of muscle weakness, presented with quadriparesis. Child had normal growth and mental milestones. Routine examination sort of flashed quadriparesis, but for that, there was nothing abnormal. The values are as shown. The child had a normal renal GFR with a creatinine of 0.8. Child had a normal blood pressure of 90. The significant abnormality you see in this investigation is a raised chloride and a low potassium with a normal sodium. So the child had significant hypokalemia. So in this background, you are doing a blood gas analysis which showed a pH of 7.3, PCO2 of 35, HCO3 of 19, PO2 of 95, and a saturation of 98. Because last class we discussed, I think one of the participants can analyze the ABG and tell me what it is. Because I cannot, you can unmute and say, I will not be able to see the chat box, okay? One of you, please analyze the ABG and let me know what it is. Any takers? Yes?
Ashish, please try to answer. When madam is asking, please try to answer. If it's okay, if it's wrong also.
You can unmute and answer. Okay.
Zora, so many participants. Please try to answer.
pH is 7.3. So what does it mean to you? Are they there or they're not there?
No, their answering is metabolic acidosis.
Okay, very good. So what will be the next step? They can unmute and answer so that they'll be also here. What is the next step?
Okay. Can you please unmute yourself to look for compensation?
Okay, very good. So what is your answer to that? So this is how it is. pH is 7.34. It is 7.3. So it is decreased. As you correctly said, it is acidosis. PCO2 is normal 40. It is decreased 35. So the bicarbonate and the PCO2 and pH has decreased. Is the same direction rule. So it is a primary metabolic process. PO2 is normal. Bicarbonate is 19 with a saturation of 98. We said, what is the simple formula to find out the compensation for the metabolic acidosis? You said metabolic acidosis with a bicarbonate of 19. So what is the simple formula? Forgot? You add 15 to 19. Okay. You add 15 to the bicarbonate value. So it becomes 34. So the PCO2 is the expected for that drop in bicarbonate, thereby suggesting it is a simple metabolic acidosis. So to recapitulate, when the pH and bicarbonate move in the same direction, the primary process is metabolic. And the simple formula to find compensation is add 15 to bicarbonate. If the values are expected value and the derived value are the same, It is a simple metabolic acidosis. Now, what is the next step? What will be the next step? Anybody? Why everybody is silent today?
No, there I asked them. There, I see it seems some network issue is there. It seems, madam. That's why.
Oh, is it?
Yeah.
Okay. They are able to listen or what?
Yeah. They're able to listen and they're answering the chat section, madam.
Oh, so what have they answered in the chat section?
Not
I
yet,
will not be able to open the chat box, right?
Yeah,
When
it's
I
okay. I'll tell it. I'll tell it you. If they post something, I'll tell, ma'am. Or else we can continue.
Pardon?
If they
Anyway, this next step is the calculation of anion gap. This is just the recapitulation of the correct compensation. I've already shown it in the last class. So the expected compensation by the correct formula is it should range from 34.5 to 38.5. That is bicarbonate into 1.5 plus 8 plus or minus 2. When you calculate, you get a value ranging from 34.5 to 38.5. Applying the simple formula, it is 34. So the patient has got a simple metabolic acidosis. We also discussed the classification of metabolic acidosis. Metabolic acidosis has been classified into anion gap metabolic acidosis and a normal anion gap metabolic acidosis. So next step obviously is to calculate the anion gap, right? So patient's anion gap here is 136 is the sodium value. If the potassium is not very high, you only take sodium. Sodium minus bicarbonate of 19 plus chloride of 108 gives you a value of 9. We said whenever you interpret anion gap, you have to correct it for the albumin value. So here the albumin is reasonably normal, so no correction should be applied. So this patient has got a normal anion gap metabolic acidosis. So we discussed anion gap metabolic acidosis in the last class. This child who presented to us with quadriparesis has a normal anion gap metabolic acidosis. Now, what is the next step? The next step is just we should know what we are looking for. So, what are the causes of normal anion gap metabolic acidosis? Most important is loss of bicarbonate that is occurring in diarrhea, especially in children. I always remember when I did my house surgery, this cannulation, etc., was not so common. We always used to do a cut down. The chubby babies getting admitted, we had a ward 4, which is what's called as a diarrhea ward. Children getting admitted, next day we go, the children are not there. Because we never had ABGs, we never had a proper cannulation, etc. So it's very sad to see them dying of diarrhea. That's one of the reasons why I could not take pediatrics. I would love to do that. So this is just to tell you the diarrhea is life-threatening for a child. So loss of bicarbonate can result in acidosis. When you recover from a diabetic ketoacidosis, the acidosis bicarbonate gets converted. So that also can produce a normal anion gap. For ileal conduit, for malignancies, etc., do a ileal conduit. So you lose fluid through the ileum. So that is rich in bicarbonate. That can also produce acidosis. When you exhibit carbonic anhydrous inhibitors like acetozolamide, dorzolamide, topiramate, etc., that can also result in a normal anion gap metabolic acidosis. Most importantly, from the nephrologist point of view, is a renal tubular acidosis. If you use a parenteral nutrition, arginine lysine can also result in normal anion gap acidosis. So this child did not have any loss of bicarbonate. There was no history of diabetes. Child not had undergone ileostomy. There was no acetozolamide or topiramate injection. Arginine lysine was not used. So probably it could either be a normal variant or a renal tubular acidosis. For a normal variant, to produce a significant hypokalemia and quadriparesis is unusual. So we should point our finger towards renal tubular acidosis. So how will you find out? Well, just like we had an anion gap in plasma, we have an anion gap in urine as well. Because urine also, contains cations and anions. The main cations that are excreted in the urine are sodium as sodium chloride, potassium as potassium chloride, And ammonium, ammonia is has an important role in maintaining the acid-base status through kidney. So ammonia is getting excreted as ammonium chloride. So the cations to repeat are sodium, potassium, and ammonium. The important anion that is excreted is chloride. We know that urine virtually contains no bicarbonate under normal circumstances. So the gap is sodium plus potassium minus chloride. We also said the principle of electron neutrality has to be maintained. So there is no real gap. It is only because we are not measuring the one cation or one anion. That's why you get a gap. Here, the important cation you are not measuring is ammonium. We know ammonium is excreted as ammonium chloride, sodium as sodium chloride, potassium as potassium chloride. So chloride is derived from three important cations, sodium, potassium, and ammonium. Whereas you are measuring only sodium and potassium as the cation, we are not routinely measuring ammonium. So naturally, chloride will be greater than the sum of sodium and potassium. So usually the urine anion gap is a negative value. When we discussed plasma anion gap, we said albumin is the important contributing factor and the serum anion gap or plasma anion gap is a positive value. Here, urine anion gap is a negative value. It can range from -30 to +30. Hope I am clear. So just like plasma, urine also contains cations and anions. The cations importantly are sodium, potassium, and ammonium. The important anion is chloride. We are measuring chloride, but we are not measuring ammonium on the cation side. So naturally, chloride will be greater than sodium and potassium. So it is usually a negative value. Okay. Now, this child has a sodium of 65, potassium of 40, chloride of 55. So here what has happened? Urine anion gap is a positive value. That is 65 plus 40 is 105, minus 55, it is 50. So the child is excreting chloride less than is expected for the child. So why is it that happening? That is happening because the child is not able to excrete or secrete ammonia combined with chloride and produce ammonium chloride. So ammonia is not getting secreted or excreted into the urine. That means acidification of urine is defective. That is why urine anion gap is positive. So when urine anion gap is positive, to repeat, that means ammonium excretion is defective, which happens mainly in the kidney. So the main cause of acidosis is kidney. On the other hand, if the urine anion gap had been negative, that is chloride was more than sodium and potassium, that means the cause of acidosis here is not due to renal. It usually suggests an extra renal cause. So here is a child who presented with hypokalemia, quadriparesis, metabolic acidosis, normal anion gap metabolic acidosis with a positive urine anion gap, suggesting a defective renal acidification. So normal value we said is -30 to +10. If urine chloride is more than sodium plus potassium, more negative, it suggests diarrhea or other gastrointestinal cause ileostomy as the cause of tubular as the cause of normal anion gap acidosis. If sodium and potassium is more than chloride, it is suggestive of renal cause. But when you interpret the urine anion gap, you should be careful because the urine sodium should be less than 20 for this equation to be applied. So this child has a urine anion gap and this is the radiology picture. Can anybody diagnose this radiology picture? What do we see in the X-ray? Anybody? Kishan Rao, anybody in the chat box?
Nephrocalcinosis, ma'am.
Excellent. So it is nephrocalcinosis. What do you think is the underlying disorder? When you see a normal anion gap acidosis with a positive urine anion gap and urine pH is alkaline and the X-ray shows nephrocalcinosis, what do you suspect? Anybody? This is a classical picture of a distal renal tubular acidosis. So when you interpret the urine pH, you should be careful that there should be no alkali producing Klebsiella or Pseudomonas in the urine. That is, you have to always do a urine culture. See that the urine culture does not grow any bacteria. And if the pH is 6.5, that means when the system is acidic, the kidney is not able to throw out ammonia, get the urine appropriately acidified. So this is suggestive of an acidification defect. It can be either proximal or distal. Here, because of the severe hypokalemia and positive anion gap to a good extent and nephrocalcinosis, this is suggestive of a distal renal tubular acidosis. So we are completing metabolic acidosis in that case scenario. Any doubts you would like to ask now, you can ask. Anything that is not clear also, you can ask now. Any doubts or questions on metabolic acidosis? Anybody? Everything is clear. Kishan, can I proceed? It's clear for them?
Yes, ma'am.
Can I proceed?
We can proceed, ma'am. Yes.
Okay. This is the second case scenario. This is the story of a 28-day-old boy who was admitted with non-bilious vomiting. Started from first week of life. On examination, child is dehydrated, low blood pressure. There is a visible lump in the right upper quadrant. So what is the clinical diagnosis you would like to suggest? A 28-year-old male baby getting admitted with vomiting, non-bilious, child is dehydrated, hypotensive, a visible lump in the right upper quadrant. What are the common conditions that comes to your mind? Any pediatricians around or pediatric house surgeons, anybody? So let us see what it is. Investigation showed a normal hemogram. Urine analysis showed a pH of 6.5 and the sediment was normal. The investigation showed a blood sugar of 90 milligram. Urea was on the higher side, 55 milligram. Creatinine was 0.6. Sodium was 129. Potassium was 2.8. And chloride was 93. What are the abnormalities you make out? One of you can answer. This becomes
metabolic alkalosis, they're telling.
No, this investigations. This investigation for the abnormalities you make out. From what I have shown. You are right, metabolic alkalosis, but what I have shown here. What are the electrolyte abnormalities we see? Anybody? So, there is hyponatremia, hypokalemia, hypochloremia with elevated urea. This is the background which we are seeing the child with vomiting. So this is the typical metabolic abnormalities resulting from vomiting. We will not go into the pathogenesis, etc., because this is a class on analysis of ABG only. Okay. So this is the blood gas value. pH is 7.46. PCO2 is 46. HCO3 is 31 with a base excess of +8. So what is your interpretation? What diagnosis you make from the blood gas? So as we discussed earlier, first step is to find out whether it is acidemia or alkalemia. You have to look at the pH. pH is more than 7.4, there is alkalosis. If pH is more than 7.45, it is alkalemia. This child has a pH of 7.46, so the child has alkalosis. Step 2, to find out whether it's a metabolic abnormality or respiratory abnormality as a primary problem. So we said same direction rule. Here the pH is increased, bicarbonate is increased, PCO2 is increased. This is simple metabolic alkalosis. Now let us see. pH is 7.34 to 46 increased. PCO2 is 40, it is increased. same direction rule. So it is a metabolic abnormality. Now class HCO3 is 31, it is also increased. Oxygen saturation is 98%. So applying the I'm repeating it over and over again because I want you to remember that is a simple rule. Okay. So this is a metabolic alkalosis. Now we have to find out is a simple disorder or a mixed acid-base disorder. The simple formula is for every 1 milliequivalent increase in bicarbonate, the PCO2 should increase by 0.6, some say 0.7. So all are applicable. The last two digits of the pH should approximate bicarbonate plus 15. If it is a simple disorder. Okay, so this child had a bicarbonate of 31 plus 15 is 46. So the last two digits of pH should be 46. So child has, if you remember, child has a pH of 7.46. That is the last two digits of pH. So expected increase in PCO2 according to the commonly used nomogram is 0.7 millimeter mercury for every 1 milliequivalent increase in bicarbonate. So bicarbonate is 31, PCO2 is 40 plus 31, which is the bicarbonate, 24 is normal bicarbonate into 0.7. That gives you a value of 44.9, that is 45. Child has a PCO2 of 46, thereby saying it is a simple metabolic alkalosis. Now, what is the expected increase in PCH we discussed? Easy to remember is you add 15 to bicarbonate. There also you said bicarbonate plus 15. Here also you are saying bicarbonate plus 15. The last two digits of the pH should correspond to bicarbonate 15 to make it a simple metabolic alkalosis. Now, how do you proceed when you confront with a metabolic alkalosis? That is role of urine chloride as a clue to etiology. Urine chloride, if it is less than 20 milliequivalents per liter, it shows gastric fluid loss, can be vomiting. Post-operative, you have put a suction tube, which is only up to the pylorus, nasogastric suction. Post-hypercapnic metabolic alkalosis, remote use of diuretics. That is, you have already exhibited diuretic, you are stopped. So when a child becomes hypovolemic, the renin-angiotensin system gets activated and will try to reabsorb as much of sodium and chloride. So in remote use, urine chloride will be less. In the current use, urine chloride will be more. Villus adenoma of the colon gives the same result. Congenital chloriduria can also produce a chloride less than 20. So when you confront with a urine chloride less than 20, in a patient with simple metabolic alkalosis, your concentration is mainly on the gastrointestinal tract. On the other hand, if the child has got a chloride of more than 20, that means when the kidney has to conserve chloride, kidney is excreting more chloride. That means the kidney is the culprit for the metabolic alkalosis, as in Bartter syndrome, Gittelman syndrome, current use of loop diuretics or thiazide diuretics, hypokalemia, hypermagnesemia, edema, post-hypercapnia, or gastrocystoplasty. Post-hypercapnemia can produce a low chloride or increased chloride in the urine. So the next step to repeat when you confront with a metabolic alkalosis is to look at the chloride. If the urine chloride is less than 20, more towards the gastrointestinal tract. If it is more than 20, it is more towards the kidney and hypercapnia. This child had a sodium of 15, potassium of 10, chloride as 15. So patient has got a urine chloride less than 20. We suggested non-renal loss. So the probable diagnosis of vomiting here is hypertrophic pyloric stenosis. So to repeat, the most common abnormality you get to see in vomiting above the level of, that is pylorocandrum, is above the pylorus is hypokalemic, hyponatremic, hypokalemic, hyponatremic, hypochloremic metabolic alkalosis with urine chloride less than 20. So this child has got a hypertrophic pyloric stenosis. Okay. Now let us see the next case, which is a little complicated. So I think we'll go to the third case first and then come back to this. This is a story of a 2-year-old child weighing 8 kg, admitted with feeble cry, polyuria, polydipsia, vomiting, constipation, salt craving, tendency for volume depletion, failure to thrive, growth retardation. Child was clinically euvolemic and has a normal blood pressure. So here is a child who is failure, in summary, failure to thrive. Child was euvolemic and has got a normal blood pressure. The investigation show urea of 20, creatinine of 0.5, sodium of 122, potassium of 3, chloride of 96, bicarb of 28, and magnesium of 1.5. So what are the abnormalities you see here? So what are the abnormalities you see here? Anybody in the chat box, Kishan? Anybody in the chat box? Hello? Can you hear me?
Yes, madam. Clearly, yeah.
Anybody in the chat box?
No response, madam.
No response.
Hyponatremia, they're telling now.
Pardon?
They're typing, ma'am. Hyponatremia. Sai Manoj is telling hyponatremia. And what about the potassium levels and chloride levels, Manoj?
Hypokalemia and chloride is borderline 96 to 106. It's on the lower side.
And what is significant about that strikes you? What about bicarbonate?
Bicarb is normal only, ma'am. 28 to 35.
No. In children, you can go up to 26. Okay. So it is alkalosis. The child has got a high bicarbonate and a normal magnesium, because magnesium we take as 1 to 2 milliequivalents per liter. So there's a significant hyponatremia, hypokalemia, hypochloremia with an elevated bicarbonate. Now, how do you proceed? pH is 7.4, PCO2 is 46, bicarbonate is 28. So we said the last class, we remember, right? Looking at the pH, you should never say it is normal. It can be either a normal pH or it can suggest a mixed acid-base disorder. So here the pH is 7.4, but if you look at the PCO2 and bicarbonate, no, both values are abnormal. PCO2 is 46, which is above the normal value of 40. Bicarbonate is 28, above the normal value of neutral value of 24. So both are increased, thereby suggesting it could be a mixed acid-base disorder, which is neutralizing each other and keeping the pH normal. So if you follow the same direction rule, bicarbonate and PCO2 has increased, that is moved in the same direction. That makes us think it is a metabolic alkalosis, right? Because bicarbonate is increased, PCO2 is increased, though pH is normal. It is alkalemia because the pH has not changed, but we are using the term interchangeably, so we'll still continue to use alkalosis. So there is a metabolic alkalosis. We are calling it metabolic because of the same direction rule. Bicarbonate and PCO2 has moved the same direction, thereby making it a metabolic alkalosis. Now, what is the expected PCO2 value for this patient? We said for every milliequivalent increase, the PCO2 should increase by 0.7. So the PCO2 should have increased only to 42.8. But the PCO2 of the patient is 46. So what does it indicate? It's already shown. That indicates accumulation of carbon dioxide in addition to what should have been expected for an increase in bicarbonate. So the child has got a respiratory acidosis also. The child has got a metabolic alkalosis. The child has got a respiratory acidosis. Both things are meeting each other. That is what is keeping the pH 7.4. It's clear? Now, we said the clue is urine chloride. So if they look at the chloride, we discuss what are the various causes. Less than 20, we are more towards GI tract. More than 20, we are considering kidney as a culprit, in addition to post-hypercapnic metabolic alkalosis. This child has a urine sodium of 35, potassium of 25, chloride of 25, calcium of 40 milligram. That is, the child has a metabolic alkalosis with urine chloride more than 20, with a respiratory acidosis, hyponatremia, hypokalemia, hypochloremia, with a urine loss of sodium and potassium and chloride. So, what could be the diagnosis? Any suggestions? Failure to thrive, growth retardation, euvolemic, normal blood pressure, present with hypokalemia, metabolic alkalosis. What are the syndromes you remember? So there is no history of diuretic intake or other known cause for hypokalemia. So the differential diagnosis would be either a Bartter syndrome or a Gittelman syndrome. To differentiate Bartter from Gittelman, easy to remember is Bartter syndrome is furosemide. It behaves like furosemide. We know that furosemide is used for hypercalcemic crisis. It acts by excreting more calcium in the urine. So in Bartter syndrome, there is hypercalciuria because it is excreting more calcium in the urine. Whereas in Gittelman syndrome, it is like thiazide diuretic. We know thiazide diuretic is used for stone formers. So calcium is low. So the differentiation from Bartter and Gittelman is estimate the urine calcium and serum magnesium. If the child is hypercalciuric and normal magnesium, it is Bartter syndrome. If the child is hypermagnesiemic and hypocalciuric, it is Gittelman syndrome. Here, the child has got more calcium in the urine. We said 40 milligram per K 24 hours. The normal expected excretion for the child is only 4 milligram per kg. The child was weighing only 8 kg. So it should be 32 milligram. So here the diagnosis is Bartter syndrome. Okay. So now we'll move on to the little difficult case. This is probably the third case in the last case we discussed today on metabolic alkalosis. A 60-year-old chronic smoker is admitted with 1 week history of fever, cough, and drowsiness. He is centrally cynosed with an oxygen saturation of 65%. X-ray test shows overinflation and bronchiectatic cavities in both mid-zones. He is administered oxygen, antibiotics, and SpO2 rises to 92%. On admission, he is normotensive, but he was hypoxic. RBS is 110, urea is 40, creatinine is normal 1.4, sodium is 134, and potassium is 4. That means he has a normal GFR and a normal electrolyte profile. But he was a smoker, admitted with COPD, exacerbation, and centrally cynosed. ABG was shunned. ABG shows a pH of 7.34 to the patient's pH is 7.29. Let me see the 7.29. So it is decreased. So we know it is acidosis, right? pH is decreased, 7.29, it is acidosis. PCO2 was 32. So we said same direction rule is metabolic, opposite direction is respiratory. Here the pH is low, PCO2 is increased to 72. So it is mainly a respiratory acidosis. What is his PO2? His PO2 was only 58 and that was on 40% oxygen. We said whenever we read the PO2, it should be read in conjunction with the FiO2. This child or this 60-year-old man was on 40% oxygen and was only giving a PO2 of 58. So the PO2 FiO2 ratio here is 58 by 0.4, which is 145, which is suggestive of an acute lung injury, acute respiratory distress syndrome. I think so much is clear because there is no response. I am not able to make out whether it's following or not. If you are not following, either Dr. Kishan Rao can stop me or I'll continue presuming that you are following. Bicarbonate is 31, it is increased. The saturation is 98%. So, we are here on a situation where a patient who is candidate for a chronic lung disease presents with respiratory acidosis with an expected bicarbonate elevation to the PCO2, making a diagnosis of respiratory acidosis. Now, let us see what is the compensation you expect for a respiratory acidosis. There are two components to it. First, you have to find out for this PCO2, the pH is moving in the correct direction. That is, again, for an expected decrease in pH, for every 10 millimeter increase in PCO2 is acute, we said, kidney takes time to reclaim bicarbonate, reabsorb bicarbonate, and regenerate bicarbonate. So the bicarbonate will not increase to the same extent as is expected for an increase in PCO2. So the drop in pH will be significant for an acute respiratory acidosis. To find out what is the expected drop, the equation is, or the formula is 0.08 into PCO2 by minus 40 divided by 10. That is all is given for every 10 millimeter increase in PCO2. In this patient, PCO2 was 72. Normal PCO2 is 40. The expected change is 0.08 into 32 by 10, giving a value of 7.144. So we should understand in acute respiratory acidosis, when the PCO2 rises to 72, the pH should drop to 7.144. We should remember here the pH was only 7.29. Okay, so let us see what will happen if it's only chronic respiratory acidosis. We said in a chronic respiratory acidosis, the reclamation and regeneration of bicarbonate is complete. So the pH may be near normal. It will not fall significantly. And the formula is, instead of 0.08, it drops only by 0.03 into PCO2 minus 40 divided by 10. So here, looking at this, 0.03 into 32 by 10 gives you 3.2. It is 0.096. The pH will only be 7.304. So if you remember, this patient has a pH of 7.29. So most likely, it is a chronic respiratory acidosis. Okay, so this patient had, to start with, the patient had a respiratory acidosis, hypoxia, ventilated, corrected, and the pH got corrected. Now let us see what happens. Despite that, this is a live case we had in Govind's Hospital. Despite additional oxygen, the patient appears increasingly breathless. He started on non-invasive ventilation by face mask. On an inspired oxygen concentration of 35% with NIV picks up to 97. The patient tolerates the mask, respiratory decreases, and he appears settled. The pH value is 7.48, PCO2 is 48, PO2 of 70, and bicarbonate is 35. So what is your diagnosis from the ABG? I think one of you has to essentially answer. Otherwise, it becomes a little boring for me. Please, one of you can attempt an answer. Already it is there, but I want you to interpret. Anybody? No takers? So pH is 7.48. There is alkalosis. PCO2 is 48. It is moving in the same direction. So it's primarily a metabolic process. PO2, we said has moved to 70 on whom giving a saturation ratio of FiO2 ratio of 350, which is normal. The bicarbonate is 35, So bicarbonate of 35 and a pH of 7.48, it is primarily a metabolic alkalosis. So you should remember, here was a patient who was admitted with hypoxia, severe respiratory acidosis, getting ventilated. Oxygen supplementation alone was not sufficient. He was on NIV. His respiratory status improved, but suddenly he moved to metabolic alkalosis. Anybody? What should be the mechanism? What do you call this condition? Anybody? Why today everybody is very silent? Only a few participants, or they are not able to comprehend, or what's the problem? Anybody?
Is it because of washout of the carbon dioxide that has occurred?
Yes. This is, which is very good. This is typically called as a post-hypercapnic metabolic alkalosis. Okay. So, in the background of COPD, treated with ventilation, euvolemic normative enzyme, normal GFR, potassium alone was low, 2.5. The urine electrolytes showed a urine chloride of more than 26. So, let us see again the urine chloride. Urine chloride can be less than 20 or more than 20 in a post-hypercapnic metabolic alkalosis. So, this patient was not on diuretic. The patient was not on normal magnesium, not edematous. He had a primary respiratory abnormality which suddenly developed metabolic alkalosis. Both are equally dangerous. So it is typically suggestive of post-hypercapnic metabolic alkalosis. So how, supposing a patient gets admitted and on ventilation, what are the causes for metabolic alkalosis? Patient can be developing pulmonary edema. To prevent pulmonary edema, they would have exhibited loop diuretics. Here, there is no history of loop diuretics. Volume depletion, aldosterone. The patient should have secondary hyperaldosteronism with metabolic alkalosis, but the patient was euvolemic, so that is not the cause. If the patient had received blood transfusion, citrate used for blood transfusion can get converted to bicarbonate, producing alkalosis. No history of blood transfusion. Administration of bicarbonate for the management of hyperkalemia or metabolic acidosis. Here there was no hyperkalemia, patient has hypokalemia, so that is not the cause. Hypoalbuminemia can really produce alkalosis, but the albumin was surprisingly normal. Loss of gastric secretions via nasogastric tube. There is no history of vomiting. There is no nasogastric suction. So none of these causes were there. The only cause we can make out is increased PCO2, respiratory acidosis, suddenly ventilated, pH corrected, patient developing hypercapnic alkalosis. Can anybody suggest the mechanism why this is happening? One of you are answering post-hypercapnic metabolic alkalosis. What's the mechanism? Why does this happen?
Respiratory centers are driven by increased carbon dioxide level. By saturating, giving the more amount of oxygen, it reduces the hypercapnia. There is a washout of carbon dioxide.
Hypercapnia, washout of carbon dioxide? Hypercapnia means what? Increase in PCO2, isn't it? This is after hypercapnia. We are talking about metabolic alkalosis. What is the mechanism for metabolic alkalosis? Maybe difficult. The mechanism that you simply should understand is, last class also we said, for a metabolic disorder, acidosis or alkalosis, the respiratory compensation is instantaneous. When somebody loses bicarbonate, the lungs increases the respiratory rate, washes out the carbon dioxide, pH is brought back to normal. When there is alkalosis, when there is an increase in bicarbonate, the PCO2 rises correspondingly and the pH is maintained. But on the other hand, this compensation is instantaneous. It happens then and there. But in a respiratory disorder, the compensation is by the kidney. So kidney takes time to reclaim, reabsorb, regenerate bicarbonate. So when the kidney has realized the PCO2 is 72. So within 48 hours, the kidney will try to reabsorb, regenerate bicarbonate, try to bring back the pH to normal. But suddenly, because the pH is low, you want to correct respiratory acidosis, you are drastically ventilating and bringing down the PCO2. But the kidney takes time to recognize that the PCO2 is low, I should cut down my bicarbonate. So it continues to reabsorb bicarbonate for some more time. See, so for a given PCO2, the kidneys were trying to reabsorb bicarbonate. So that continues to happen for 40 to 72 hours. But suddenly, because we have ventilatory support, you are bringing down the PCO2, but the bicarbonate reabsorption continues. This is the mechanism of a post-hypercapnic metabolic alkalosis. So the treatment is acetazolamide, usually. So unless you recognize this, you will not, you will try to give some acids or you try to look for other causes. So this entity should be corrected because metabolic alkalosis can result in cardiac arrhythmias. So that we are going to discuss now. So now there is a metabolic alkalosis. We said urine chloride should be done. That gives you a clue to the etiology. Similarly, urine potassium also in a patient with a normal creatinine can give you a clue. If the urine potassium is more than 20, again is Barter, Gittelman, current use of thiazides, diuretics, hypomagnesemia. If it is less than 20, it may suggest a laxative abuse. So now let us see. Now we have discussed a consolidated metabolic alkalosis. So it is a primary increase in bicarbonate with or without a compensatory increase in PCO2. It can result from loss of hydrogen ions or gain of bicarbonate, loss of H ions as in vomiting, ileostomy, etc. Or can be a gain of bicarbonate in a bicarbonate infusion or a diuretic use. Alkalosis is a process in which bicarbonate is in excess, but it is buffered so that pH is maintained below 7.45. Alkalemia is the correct term to use when the pH increases above 7.45, but we usually use it interchangeably. Why are you so worried about this? Because it has got a clinical significance. It contributes to 50% of all acid-base abnormalities. When the pH is more than 7.55, the mortality is around 45%, 40%. More than 7.65, survival is very difficult. Why is it difficult? Because alkalosis reduces ionized calcium, reduces ionized magnesium. It immediately produces cardiac arrhythmias and sudden death. So early recognition and correction is important. So now let us see. So far we had been discussing patients with metabolic alkalosis, urine potassium wastage, and normal blood pressure. The causes we said could be a Bartter syndrome, could be a Gittelman syndrome, could be diuretics, current use of diuretics, could be a post-hypercapnic metabolic alkalosis. But here is a situation where there is a metabolic alkalosis and patient is hypertensive. What is the algorithm here? So when there is a metabolic alkalosis with a normal ECF volume and hypertension, first you have to look at is the aldosterone. If the aldosterone is increased, then you have to look at the plasma renin activity and renin-aldosterone ratio. If there is an increased plasma renin activity, you know that aldosterone is getting secreted by adrenal cortex zona glomerulosa in response to plasma renin. When there is increased plasma renin, that means there is ischemia to the kidney. So the most important cause is when there is hypertension. It could be a unilateral renal artery stenosis, a bilateral renal artery stenosis, renin secreting tumors, or it could be a malignant hypertension. Secondary hyperaldosteronism due to liver disease, etc., seldom produce hypertension because there is a low effective intravascular volume. Because there is ascites, poor effusion, etc., due to hypoalbuminemia, blood pressure does not increase. But when there is a hypertension and aldosterone is increased in response to high renin, we know it could be related to renal artery. Either it could be a unilateral artery stenosis or a bilateral artery stenosis. It could be a renin secreting tumor or it could be a malignant hypertension. If the plasma renin activity is normal, aldosterone ratio is significantly elevated, we know the aldosterone is not responding to renin. It is autonomous. It is behaving on its own. So it is very suggestive of a primary hyperaldosteronism. We also should remember that primary hyperaldosteronism, as earlier thought, is not rare. If we look for it, 1% of, that is 1 in 100, secondary hypertension is due to Conn syndrome or a primary hyperaldosteronism. The metabolic abnormality gives you a clue. There is metabolic alkalosis, potassium wasting, that is hypokalemia, chloride wasting in the presence of relatively normal renin and a high aldosterone. You do a MRI imaging of adrenal, it may show an adrenal adenoma or adrenal hyperplasia. If it's an adrenal adenoma, surgery is the treatment of choice. Hyperplasia can be medically managed. So it's very important to recognize aldosterone producing tumors or adrenal cortex problems in a patient who present with metabolic alkalosis and hypertension. On the other hand, if the patient has got a low aldosterone and a low renin, the next one you have to look at is cortisol. If the cortisol is elevated, we know that adrenal cortex is again the culprit. It could be a Cushing syndrome or a iatrogenic Cushing syndrome. We would have given steroids for some other cause. The patient would have developed hypertension. If the serum cortisol is normal and the aldosterone is low, renin is low, patient has got a metabolic alkalosis, the common condition, the syndrome you have to remember is a Liddle syndrome. So, metabolic alkalosis, to conclude, can present with normal blood pressure, high blood pressure. Metabolic alkalosis can be due to gastrointestinal cause like diarrhea. Metabolic alkalosis can be due to renal cause like Bartter, Gittelman, hyperaldosteronism, secondary hyperaldosteronism, Liddle syndrome. So you should judiciously apply your investigations and get into a diagnosis of metabolic alkalosis. So in the last 1 hour or so, we were trying to discuss metabolic alkalosis and the normal anionic metabolic acidosis. We said when you have a normal or a non-anionic metabolic acidosis, as it currently called, you should look at the urine anion gap. If the urine anion gap is increased, is a positive value, again kidney is the culprit. You have to identify the coexisting abnormalities, electrolyte abnormality or a mixed acid-base abnormality. In a patient who is on ventilator, if they develop metabolic alkalosis, you should carefully find out whether it's a post-hypercapnic metabolic alkalosis. If they develop cardiac arrhythmias, you know, the lungs are vulnerable, heart is vulnerable, that may lead to mortality. So you may have to exhibit acetosolamide. The clue to metabolic alkalosis can be urine chloride and urine potassium estimation. In addition, if the patient has got hypertension, you have to look at aldosterone and renin. If the patient has got a high aldosterone, high renin, it is a secondary hyperaldosteronism with a volume expansion or secondary renal artery stenosis or unilateral or bilateral. Secondary hyperaldosteronism due to liver disease does not produce hypertension because the effective intravascular volume is low. If the patient has got a normal high aldosterone and normal renin, it is Conn syndrome or primary hyperaldosteronism, which is not at all uncommon. We see at least 2 cases a year in a private setup, you know, so medical college may much more. If the aldosterone is low, renin is low, patient is hypertensive, and there is metabolic alkalosis with a urine chloride wasting and potassium wasting, the next step is cortisol. If the cortisol is elevated, it could be either a Cushing syndrome, endogenous Cushing syndrome or iatrogenic Cushing syndrome. If the cortisol is low, the renin is low, aldosterone is low, it could be a Liddle syndrome. So this is how we approach a normal anion gap acidosis and a metabolic alkalosis. Thank you.